The future of education and training in robotic-assisted surgery.
Thank you for that introduction, and thank you for inviting me here to Malta, one of my favorite places on this planet. Thank you to the Honourable Joe Etienne Abila, who gave me that introduction and invitation. I'm going to speak to you a little bit along the same lines that you've just been hearing about from the previous speaker, about how we introduce safe innovation and intervention, and in particular in relation to robotic-assisted surgery, which of course has great implications for helping patients, but also has the potential for causing great harm. So I'm an esophageal and gastric cancer surgeon, and these are the patients I dealt with for 30 years in a maximally invasive way. Open Surgery, many of them hugely obese, because that is associated with the development of adenocarcinoma of the esophagus. And it's moved on to minimally invasive surgery, and of course now the potential for robotic-assisted surgery. And that's important, that differential, because patients don't quite understand the difference between robotic-assisted surgery and robotic surgery. They think that a robot is going to do their operation. That's not the case. It's robotic-assisted, and it's important that patients have the knowledge and understand what is going on. So, great that we moved on to minimally invasive surgery and the potential robot. And the great thing is that I believed 6-7 years ago that the robotic-assisted surgery had real implications for improving outcomes from minimally invasive surgery. All the studies have shown that maximally invasive surgery, as I call it, and minimally invasive surgery had no benefit. There were no differences. But robotic-assisted surgery was going to really advance minimally invasive surgery because it was going to standardize the way we operate. It was easier to train. You could sit in dual consoles, and you could also make more consistent the radical lymph node dissection around the aorta, around the tracheobronchial tree. So I really believe that the robot was going to be the answer to all of this in terms of getting minimally invasive surgery more consistent. The other, I should say from the start, I personally have no declarations of interest, but the Royal College of Surgeons of Edinburgh, which I'm going to talk about here, has a partnership with Intuitive, who helped us set up our laboratory, our clinical skills laboratory at the college. So whilst I was president of the college in 2018, I set up a college task force in order to look at how we introduced clinically and some governance over the development of robotic surgery. And I set up this group which included representatives from all the surgical specialties. It included a lead for simulation, because that is the key behind the training, and also a lead for non-technical skills of surgery. In other words, the things that can actually affect patient outcome that aren't technical. And that is the whole extended surgical team. And so we had the conveners of the education department, and we had our leadership fellow who helped us to run this. And there were key work streams. First of all, and most importantly, we had a new area of practice here. And our college is all about standards and safety of patients. That's what we are there for. And so what we had to do was to set up a way of getting over to the trusts, the hospitals all around the United Kingdom, a safe way of developing this innovation of robotic-assisted surgery. So that was the first thing, but we also had to develop Courses, very important. Develop courses at all levels, from the very junior surgeons to the senior trainees who are doing more specialized work. And coming out of COVID, we ran loads of webinars on this in a series of webinars, and it was hugely important that we developed clinical and fellowships in these robotic-assisted surgical areas. And so the first thing we did, most importantly, was to develop this document, which is a 20-page guidance document that was sent out to every hospital in the United Kingdom. It's on our website. You just have to go to the Royal College of Surgeons of Edinburgh's website, and it will introduce you to this document, which first of all deals with that governance issue of developing that service. And so we got this out to all trusts, all hospitals in the whole of the United Kingdom straight away. The next thing, of course, after that is that we had to get the training right for the juniors. And we have to start at the most junior level. Core trainees, surgical trainees, needed to be introduced to this whole new concept of robotic-assisted surgery. And the only way to do that was to introduce it in a clinical skills laboratory, which is safe, where patients aren't at risk, and simulation is absolutely key to this. And then you, of course, move on to selection of patients and embarking on clinical surgical procedures and how you choose the right patient, and also, crucially, how you get informed consent for patients to agree to having a robotic-assisted operation. Absolutely key to all of this. So there are three aspects to robotic surgical training. The first is the theoretical component, which at the top here. These are absolutely crucial, that you can learn in the clinical skills laboratory and getting familiar with the technology. And then you move on into embarking on clinical cases and how the case selection, and also involving non-technical skills, your extended surgical team understanding what the issues are with robotic surgery. And then finally, and most important, is that you have continuous quality improvement by auditing your results carefully, reassessing them, and improving. So this is essentially, we outlined this structured clinical pathway for the commencement of robotic-assisted surgical cases. And first of all, of course, it's preceptorship, what we call preceptorship, which is observing the cases in a clinical environment. And we as a college can actually assist in that development. And then moving on to simple cases and proctorship, and then on to more complex cases. Now, this is our clinical skills laboratory. We have 2 Da Vinci, which are intuitive robots, in our clinical skills lab. And this is the introduction to core surgical trainees for the whole of Scotland. Happens in this laboratory. So we're very proud of that. And that has been a great success over the last year. You can't do these things on your own. Scottish Government invested in 10 Da Vinci robots, and they were distributed to the health boards around Scotland, and we were the designated partner to make all of this happen. And we set up the Clinical Skills Lab. This was in a big media campaign to demonstrate what we had to offer. And when it came to surgical training, we chose in particular 3 specialties to concentrate on. Urology has been using the robot for years, and particularly in the role of robotic radical prostatectomy. And so the urologists were key to this. Thoracic, small specialty, small application, but very easy to develop. The more challenging thing was colorectal, a huge area, huge volume of work, but we concentrated on those 3 specialties, and we were going to bring in upper GI and HPB and ENT at some time in the future. But that is how we have developed this. You can't do this alone, as I said. We had Scottish Government behind us. We got all the Royal Colleges together. We got Intuitive, and we got the Scotland Academy, and we had NHS Education Scotland, who are responsible for trainees in surgery, all on board. And essentially, the 2 aspects to this was you had to get the people, and you had to get the process. And you had to identify the training program directors, the directors of medical education to buy into all of this, and then you had to have the access to the technology which we had at the college in the clinical skills environment. And so, in summary, what we have done is that we have set up the ability to learn outside of the theatre in clinical skills laboratory, the basics of robotic-assisted surgery. We then have moved on, and we can, there are so many videos and so many modules online that individuals can join at no extra cost. And then where we really help is that collaboration with the theatre, the operating environment, with dual consoles to train the more senior trainees of the surgeons of the future. And so, to summarize, the college has recognized this very important innovation, and that it needs to be properly administered. I have to emphasize that minimally invasive surgery, when it was introduced for esophagogastric cancer, was an unmitigated disaster. Patients died. And as the Honourable Joe Abela mentioned, if a surgeon has a toy, he'll play with it. We have to be very, very careful about how we introduce these things. Patient safety is absolutely key to all of this. Thanks very much indeed.